Thank you so much to the organizers for inviting me here today to discuss informed consent in disorders of consciousness, a field whose questions are endlessly intriguing and rapidly expanding. What I hope to provide is a clear framework for understanding the challenges to informed consent encountered in caring for patients with disorders of consciousness, and an approach to navigating some of the key emerging issues pertaining to consent that are frequently encountered in caring for patients in this vulnerable population. My interest in this topic took root prior to medical school when I was in college and graduate school immersed in philosophy. Issues relating to consciousness, what its boundaries are, how to characterize it, and how something so phenomenologically rich emerges from our neural repertoire seem to me to be at the core of efforts to understand what matters most in the human experience, which is a goal shared by philosophers, ethicists, and clinical neuroscientists. When I later entered medical school and residency in neurology and fellowship in neurorecovery, I was struck by how these concepts were defined and operationalized in a way that forms a separate yet complementary matrix for thinking about some of the really challenging problems that philosophers and ethicists have been grappling with for ages. As you've learned from some of the previous speakers, especially on consult services, clinicians are routinely called upon to opine about patients' levels of consciousness following severe brain injury, to predict outcomes when consciousness is lost or diminished, to identify opportunities for fostering recovery, and to counsel families on what they might expect and how to prepare. In turn, the assessments and recommendations that are provided commonly form the dominant axis around which weighty ethical decisions are made regarding the intensity of treatment that ought to be provided. That our assessments of degrees of consciousness and capacity for recovery figure so prominently in decisions to limit or continue treatment speaks powerfully to the centrality of consciousness to our concept of personhood, and for many, what makes life worth living. Questions of how to respect autonomy when capacities which are prerequisite to autonomy are themselves disordered, as they are in coma and other disorders of consciousness, are especially germane here. Maximizing a patient's voice when their preferences and subjective experiences are unclear, as they often are in disorders of consciousness, can be immensely challenging. Viewed in this way, the ethical importance of having clarity on how to approach these sorts of discussions and decisions becomes immediately clear. Osler once described medicine as a science of uncertainty and art of probability, and perhaps nowhere is this more true than in the practice of neuroprognostication and related consent processes. Decision-making here crucially depends on a clear understanding of likely outcomes and alternative treatment choices. And yet, in disorders of consciousness, the uncertainty that often shrouds outcome assessments and sometimes assessments of levels of consciousness may complicate the ability of clinicians to straightforwardly inform surrogates. In turn, this could at times limit the capabilities of surrogate decision makers to make fully informed judgments. Neuroprognostication is a complex process that involves integrating vast amounts of information to predict a patient's likely outcome, and implications often inform high-stakes conversations about the approach to goals of care. Because of the plurality of the functions of the nervous system, neuroprognostication can be more complex than other forms of prognostication, where the affected organ or impact of disease may be more circumscribed. Depending on the etiology, this can take several forms, predicting the deterioration or recovery of a single function, of several functions, predicting the potential for reemergence of consciousness, or the overall likelihood of disability. The factors that influence these assessments can be highly variable and prone to confounding. A study by the Canadian Clinical Trials Group described substantial variation between and among different clinician groups in perceptions of neurological outcome following brain injury. Because of its complexity and uncertainty, this process is at times prone to cognitive biases, including self-fulfilling prophecy bias, where outcome predictions drive decisions that actualize those very predictions and potentially confound available outcomes data and consent processes. Research has also highlighted the importance of cultivating a tolerance of uncertainty within the culture of clinical practice, as an aversion to ambiguity may allow for the introduction of bias and premature clinical decision-making as it is mediated through informed consent processes. In providing consent to clinical care, many surrogates pose fundamental questions of, is their loved one conscious? And if not, will that change? And if so, how can we catalyze recovery? Therefore, clarity about what is meant in the first place when we use the term consciousness in consenting surrogates in treatment is essential. A particularly insightful comment found in the introduction of Plum and Posner's classic book on the diagnosis of stupor and coma, where some of these initial diagnostic categories were defined, is worth mentioning. Plum and Posner remark that the limits of consciousness are hard to define, and we could only infer the self-awareness of others by their appearance and their acts. From the outside in, the limits of consciousness and the boundaries defining its presence or absence are notoriously fuzzy. This is both due to the crude nature of the methods traditionally used to detect consciousness, as well as the ill-defined and fluctuating nature of consciousness itself. So how do we define consciousness? Philosophers have debated this topic for millennia, and here we've taken stock of a range of different theories and definitions proposed by key thinkers over the years. And while I won't go through each of these, they're brought together here simply to highlight their heterogeneity and to underscore the inherently elastic and ill-defined nature of the concept of consciousness alluded to by Plum and Posner. Surveying the landscape of what we've come to learn about consciousness, it's become clear that this is not a unitary state, but rather more likely to be a cluster concept that includes a number of crisscrossing ingredients, each of which in isolation is not sufficient, but when variably combined, produce a range of states that fall on a spectrum of what we dub consciousness, and each of which might be variably disordered across the range of conditions that we're called to see. In counseling and communicating with surrogate decision makers, it is crucial for clinicians to be clear about how they might be using philosophically laden terms such as consciousness, for which there may not be any clearly or uniformly accepted definition. In medical decision-making and research, the process of voluntary informed consent is anchored to preserving patient autonomy. In the absence of consent, the risk of decisions being made that contravene patient preferences and thus abrogate a patient's autonomy is heightened. And this is especially the case in disorders of consciousness, where patients ordinarily are unable to actively participate in decision-making. The doctrine of informed consent in clinical medicine and research was ratified in the Nuremberg Code, Belmont Report, and Declaration of Helsinki, and later crystallized in canonical work by bioethicists and moral philosophers that framed informed consent as an ethical imperative. Regulatory codes in the United States and other conventions in the European Union recapitulate these ethical imperatives. In the US, legal requirements for obtaining informed consent are codified in the Code of Federal Regulations, or CFR. CFR allows an authorized healthcare proxy or surrogate to make decisions on behalf of an incapacitated patient according to a substituted judgment standard. Who qualifies as a legally authorized representative to provide surrogate consent varies by jurisdiction. While many jurisdictions have legal mechanisms that automatically designate close attachments as legally authorized healthcare proxies, some do not. In Massachusetts, where I practice, a spouse, family, or friend does not automatically have the authority to make surrogate health decisions for an otherwise unrepresented person unless explicitly appointed to do so. CFR also describes exceptions to the requirements of informed consent including situations in which informed consent cannot be obtained because of an inability to communicate, or when time is not sufficient to obtain consent from a legally authorized representative, or when there is no available alternative method of approved or generally recognized therapy that provides an equal or greater likelihood of saving the life of a patient. In such instances, clinicians may proceed with treatment without consent only if it is believed to be in the patient's best interest, a posture reflective of what is sometimes referred to in the moral philosophy literature as a best interest standard. Divergent philosophical perspectives and attitudes surrounding autonomy, paternalism, individualism, and other concepts have inspired varied approaches to conceptualizing and prioritizing consent across cultures. For example, collectivist conceptions of personhood, family, and interdependency have been theorized to influence family-oriented paradigms of informed consent in Japan and China. In EU states, legal and regulatory standards around informed consent stem from the Convention on Human Rights in Biomedicine, which has been in force since 1999. While studies involving patients with disorders of consciousness pose a unique challenge to the traditional doctrine of informed consent insofar as participants, by definition, are unable to consent or actively engage in first-person decision-making, discovery of novel therapies for this population is crucial, with survivors facing severely limited treatment options and high rates of morbidity and mortality. Therefore, rather than categorically disenfranchising incapacitated persons with disorders of consciousness due to inability to provide direct consent, alternative models to responsibly study individuals with disorders of consciousness have been explored. In addition to proxy consent, these include consensus consent, deferred consent, community consultation, and waiver of consent. Elements of each of these paradigms might be variably integrated into a dynamic approach to informed consent for patients with disorders of consciousness in both research and clinical practice, where variation in patient capacity or surrogate availability is anticipated. Despite extensive scholarship on alternative methods to informed consent, ethical questions remain regarding the optimal form these approaches should take, and whether approaches to bypassing first-person consent in research programs should parallel those used in clinical practice. And I would refer you to the 2020 American Academy of Neurology position statement on ethical issues in clinical research in neurology, which has explored some of these challenges in greater detail. When involving surrogate decision makers in discussions surrounding substituted judgment, it is crucial for clinicians to avoid language that might lead to therapeutic misconception or false expectations, or to suggest that an investigational intervention has established clinical benefit. In the course of clinical care for a person with disorders of consciousness, it is possible that an individual may experience recovery or discovery of functional communication. And in such instances, clinicians should reapproach the patient to orient them to the clinical contexts and offer them the opportunity to express their perspectives on what might be going on and their consent, assent, or dissent to ongoing clinical care and clinical decisions. For patients who are found to be covertly conscious, that is, those who appear behaviorally unresponsive at the bedside, but demonstrate the ability to volitionally modulate brain activity under neuroimaging or EEG paradigms, important unanswered questions exist about whether and how clinicians and investigators should approach issues of consent. Further empirical neuroethics research is much needed to better understand the attitudes of patients and surrogates surrounding optimal approaches to consent in disorders of consciousness. Innovations in detecting consciousness come at an especially exciting time as we're learning more about opportunities to promote recovery in disorders of consciousness through novel therapeutic interventions. While these innovations carry immense promise, their use will require exquisite sensitivity to ensure informed and goal-concordant implementation through appropriate consent frameworks. Thank you so much for your attention, and I'm happy to take any questions now or by email.